Thank you. Hello and welcome everyone to today's webinar, The Dialectical Supervisor, Utilizing Dialectical Behavior Therapy, DBT, and the Discrimination Model as a Clinical Intervention, which is hosted by ARCA as part of our webinar series. And this happens to be the last webinar series in my presidential year, and I'm so excited to have Dr. Richardson Booth doing that. My name is Christine Sacco-Benny, and I will serve as your host for today's webinar. Before we get going, just to inform folks who are here, there will be a link in the chat for you to sign in for your CEs. We do ask that folks keep their mics off, but to please put your questions in chat, and we'll make sure that Dr. Richardson Booth has some time at the end to answer your questions. At this time, I would like to introduce my friend and colleague, Dr. Taryn Richardson Booth, who is a clinical assistant professor in the neuropsychiatry and behavioral science at the University of South Carolina Floyd School of Medicine in the Counseling and Rehabilitation program. Since entering the field, Dr. Richardson Booth has cultivated a multifaceted career where teaching, scholarship, service, and leadership converge to enhance counselor preparation and elevated professional service. And I can attest to that because she's seen both clients and supervisees today already before today's presentation. Complementing her faculty role, Dr. Richardson Booth maintains an active clinical caseload serving medical students and the local community. Her work remains deeply rooted in promoting and well-being of individuals with disabilities and those navigating the complexities of mental health and career transitions. And with that, I turn the floor over to you. Taryn, thanks so much for being here.
Thank you so much for the invitation, and thank you all for having me. Good afternoon, everyone, and thank you for joining today's ARCA webinar series. As Dr. Sacco-Benny mentioned, I am Taryn Richardson Booth, and I am incredibly excited to share this space with you all on Juneteenth, on the weekend of Father's Day, on the weekend of summer enrolling in. Thank you so much for sharing the space with me today. I wanted to talk with you all about something that I've recently become interested in, and that is the dialectical supervisor. Being able to utilize DBT and superimpose that with the discrimination supervision model as a clinical intervention. So in our field, we have spent an enormous amount of time talking about how to intervene clinically with our clients. We talk about our different modalities that we use, evidence-based practices, and treatment plans. But today, I am asking that we kind of shift our lens a little bit, and we're going to look directly at the supervisory relationship itself. Looking at how we can explore how to transform supervision from a routine check-in, focusing on just administration, duties and tasks, and focusing a little bit more on that clinical standpoint and looking at it as an intervention that can insulate our counselors from burnout, as well as positively influence client outcomes. So we've already kind of gone through my introduction, but in addition to all of those great things that have been said about me, I'm also a mom to a 5-year-old and a wife. And so some of these skills, honestly, I do use in my private life in terms of mindfulness and just finding ways to decompress. But I am deeply passionate about working with our students here, site supervisors, as well as being able to serve the Floyd School of Medicine and the community with offering a service. So because I sit in both the educator's chair and the clinician's chair, I see firsthand the unique occupational strains our counselors experience. And that brings me to what I hope that we'll be able to accomplish today. So by the end of our time together today, my goal is for us to be able to do 4 core things. First, we're going to analyze the intersection of Bernard's classic discrimination model and the dialectical behavior therapy, or DBT, to build a comprehensive framework for clinical rehabilitation supervision. Second, we'll conceptualize exactly how supervision can function as a primary clinical intervention to directly improve outcomes for clients navigating chronic conditions, disabilities, and complex mental health disorders. And thirdly, I hope that we'll be able to take a look at how to synthesize specific DBT skills to be able to strengthen our supervisory alliance and actively mitigate some of those concerns that we see often that our supervisees or even ourselves may be experiencing. And finally, we're going to look at how to utilize one of those tools that DBT offers, a behavioral chain analysis within a supervisory framework, just to deconstruct clinical impasses and facilitate counselor problem solving. So let's start by grounding ourselves in the reality of what our supervisees are actually facing. When we look at the empirical literature on counselor development, we know that counselor education programs, just from the work that we're doing, work tirelessly to build those skills and confidence. But novice therapists of all professions, all specialties, as we know, can become easily overwhelmed earlier in their careers. So literature points out that our counselors in training encounter challenges such as acute performance anxiety, the weight of feeling constantly scrutinized or, via feedback by supervisors or gatekeepers. They may experience fragile or incomplete professional identities and also self-consciousness. When our trainees experience a heightened anxious self-focus, they often get trapped in their own heads. And I'm pretty sure that we've either heard it or we've said it to someone that you got to get out of your head. And what happens is they're busy evaluating their own performance and worrying about perfection, and that often they become lost in that and they lose the capacity to be fully present, engaged, and empathetic with the client who's in front of them. Specific to rehabilitation counselors, this reality is further compounded. So we have some literature that points out how the professionals who are in our state federal vocational rehabilitation settings are managing high caseloads, high acuity case needs, and there's also a heavy administrative load in terms of the paperwork, maybe experiencing some time pressures and institutional demands that can increase demands for them to be able to increase those successful case closures. And just from looking at the literature, and maybe even from our personal experiences, topics that involve crises, such as suicide and client self-harm, they create a baseline of anxiety and confusion. Often, what the literature says is that most students in their practicum, about maybe 50% of them, will encounter some cases that involve suicidality or any, background of self-harm. And sometimes, although they are equipped to do it from a knowledge standpoint, being in that physical setting with a real client and the self-doubt can bring about some concerns. But there's also some literature that points to the need for increased um, training to be able to support that competence and confidence. And what it shows is that being able to do this does not naturally improve over the years or with a certification or licensure status alone. It requires an explicit and intentional training and support. And when you mix that performance anxiety that I spoke about earlier with the intense systemic, demands with these crises that our clinicians are facing, we kind of get a recipe for some emotional exhaustion. So I want to see if you can either come off of mute or drop it in the chat. What do you think some of the costs of maintaining a therapeutic face? And I'll go through what that is in a few seconds. What happens when our counselors are kind of feeling drowned with this strain? Loss of connection to the client, yes. Burnout, absolutely. Burnout wins. I see a couple of that. It removes the humanity from the room. Yes, thank you, Robert. Yes, we spend a lot of time with them as supervisors. And a desire to leave the profession, low satisfaction. It's like masking for someone who's neurodivergent, correct? And avoidance of certain issues. Yes, thank y'all.
Excuse me, Dr. Richardson Booth, may I please ask the question?
Sure.
Yes, my name is Diane, and I've enjoyed your presentation. When you say burnout, loss of feelings, do sometimes individuals become so burned out that they totally quit the profession? Because there's a high turnover rate with social workers and counseling because the work is so very intense. And sometimes you do try to keep it professional and objective, but sometimes it can be difficult because of the situation, and you're not to become professionally attached to the client. But you have heard many people say they went to school and it's so much they don't want to do anymore. Do you find that to be true?
Yes, and that's actually, thank you for your question. That's actually supported in the literature that often what happens is, and I'll get to some of those statistics in a little bit, but what happens is they become so overwhelmed that they experience the burnout, they end up having some compassion fatigue, and they end up wanting to leave the profession, or they may want to leave the agency. So yes, thank you for your question. So you all kind of hit the nail on the head. When our counselors are drowning in this strain, and just based on the question that we just discussed, they are put into what we call this rigid professional therapeutic phase. It's also called, emotional labor in a sense. And this is, being, it's not a negative thing by any means, but when not addressed or when not processed in supervision, it can have some negative implications. So what happens is this mask is trying to remain neutral, trying to be empathetic with our clients, and we end up practicing this heavy emotional labor. And what happens is we suppress our natural human reactions. So some research on countertransference struggles notes that therapists frequently grapple with difficult to endure internal feelings such as aversion, boredom, anxiety, or even self-doubt. But because of the professional ideal, they feel that they must present as perfectly empathetic. And this creates an internal conflict, leading to feelings of inauthentic therapeutic interactions, which then is followed by potential professional shame. So there's also a notion of kind of, considering the clinicians who have their own lived experiences with mental health distress or recovery. Some of the literature points out that they carry a heavy psychological tax of trying to maintain a strict identity that is separate from their past patient self and their current professional self. Worried that if they show a crack or if they seek support, that whether they're in peer consultation teams or in supervision, they feel that they may be judged or viewed as being incompetent or impaired. So research also highlights that meeting someone at the edge is something that we can kind of embrace when we see that either someone has the lived experience or we understand that they may be having some internalized feelings. Some other things that happens is when a counselor works with aggressive, highly resistant, or crisis level clients, they have to exert a lot of physiological effort to stifle their natural flight, freeze, or fight responses. And they do that just so that they can remain compliant in that professional role. And we can see how this might be able to create a little bit of a dangerous double bind. So the counselor feels trapped in a shame performance loop. They feel a natural human reaction. They judge themselves for it. They suppress it to keep the therapeutic face intact. And then that suppression incurs the somatic cost of it may be benefiting or manifesting in terms of chronic fatigue, tension, panic attacks. We're all probably familiar with our inner critic. We know that voice all too well. And so, dealing with some of those self-critical cognitions that often cross-contaminates into our private lives. Some other things that also come up is scholars have documented that when organizational cultures forces counselors to prioritize productivity and paperwork over processing this emotional labor, it directly drives that job dissatisfaction, that burnout that we spoke about earlier with the question that was posed, and even early career attrition. So what the research shows, and this is that statistic that I was referencing earlier, is that, and this is within rehabilitation. This study was conducted within rehabilitation counseling, but it shows that nearly 30% of counselors intend to leave their jobs, and they are within 5 years, less than 5 years in the field, and under 36 years old. So this occupational stress is kind of driving them out. And I'll share a story. I mentioned that I work closely with site supervisors. We're at the midpoint. We had our midterm evaluation meeting with one of our students yesterday, and I was wrapping up the meeting and thanking the site supervisor for hosting our student and the work that she's doing with her. And she shared that this is workforce development for her as well from a supervision standpoint, in that 75% of her office is up for retirement in a few years. And so she's thinking about the work that she's doing in terms of supervision, laying that strong foundation for our student in the hopes that this will be a rewarding practicum and internship experience. And ultimately, if there's a position available, to hire them on, because she's thinking about that pipeline and the role that a supervisor takes in not only shaping the professional development, but also making sure that we maintain the clinicians that we need on staff, and increase our retention, and just ensure that we're not having some of our younger counselors leave the field and want to leave the field within less than 5 years of completing their degree. So this brings me directly to my central suggestion, which is that supervision must function intentionally as a primary clinical intervention. When clinical supervision is missing, or when it strictly is focused on the administrative tasks, clinicians' growth plateaus very quickly, honestly, often within the first 5 years. And there was a study that I saw that mentioned some people go quite a bit of time without having any contact with a supervisor. And if it is, supervision, it's more administrative. But quality supervision and responsive supervision can act as a protective factor for our supervisees. So I'm pretty sure we're all familiar with what the definition is, but for the sake of being on the same page, supervision is an intensive, interpersonally focused, one-on-one relationship explicitly engineered to support professional development, ensure consumer welfare, and foster ethical practice. And this intensive relationship is the vehicle for the supervisory working alliance, which is empirically linked to heightened trainee satisfaction, clinical self-efficacy, in addition to it being proven to aid in decreasing emotional exhaustion and increasing organizational commitment and retention. So in our specialized rehabilitation and counseling context, supervision is an essential function. It provides the vital relational safety net required for personal and professional check-ins. It is the one space where counselors can safely take off that therapeutic face, lay down that mask, process those internal stressors or distress, countertransference. Countertransference was one that came up a lot for me in the spring with my practicum students, and the vulnerability to be able to come in to group supervision and share that. You have to be able to cultivate that space for students to feel comfortable to be able to do that and talk through it so that we can work through what are some of those things that may be coming up. And it also serves as a way to restore that internal regulation. Our nervous systems can be a little in flux if we're stifling those natural fight, flight, or freeze responses if we're in some of those situations. So by intentionally using supervision as an intervention to support counselors' well-being, we directly preserve their professional self-efficacy, which in turn elevates the quality of care that is delivered to the clients that we're serving. So to operationalize this paradigm shift, let's look at the structural anchor here that I'm pretty sure we're familiar with, and it's Bernard's classic discrimination supervision model. So this model is highly celebrated and studied and utilized because of its conceptual blueprint that outlines 3 distinct roles that a supervisor can take on, and the 3 lenses through which we can evaluate a supervisee's work. So let's quickly review the roles. The supervisor can put on the hat of a teacher, where they can focus on instruction, skill acquisition, and technical mechanics. They can shift into the hat of the counselor, where they can focus on the supervisee's internal processing, emotional reactions, and self-awareness. Or they can wear the hat of the consultant, operating as a collaborative peer to facilitate case conceptualization and system navigation. The supervisor maps these three roles across three specific foci. That is intervention, where the where we're focused on what the supervisee is actually doing in the session. So what techniques they're using, what are some of those clinical behaviors. Conceptualization, this is how the supervisee is thinking, their ability to understand case dynamics, themes, and systemic factors. And then there's the personalization. This is who the supervisee is in the room, how their personal style, countertransference, and somatic stress impact the therapeutic relationship. Now, while the discrimination model is an incredible framework and it tells us when we can switch into those roles, one thing that it doesn't provide explicitly is active behavioral language that we might be able to use in those roles when counselors are faced with this occupational distress. So to be able to find that language, we can superimpose this with DBT. And I'll add before I get into this that the discrimination model has been infused with ACT, and it also has been infused with Discrit as well within rehabilitation counseling. So it has some precedent of it being infused with other theories. So when it comes to DBT, this is, as we know, an evidence-based cognitive behavioral framework that was originally developed by Dr. Marsha Lennon. And as one of the most widely employed evidence-based practices in modern psychotherapy, DBT's core power rests upon the dialectical philosophy that the fundamental understanding that radical acceptance and dynamic change can coexist at the same time. So while this was designed for borderline personality disorder, there's been a body of research and literature that has established DBT's standalone skills training as transdiagnostically effective for emotion regulation across different settings and populations. So it's also been demonstrated for its robustness in terms of treating substance use, eating disorders, anxiety, treatment-resistant depression, and bipolar, while also being able to increase work role satisfaction for individuals with multiple diagnoses. The fundamental goal for DBT is simple, but it's transformative. It is to teach individuals to be fully present in the moment, to healthily cope with stress, regulate intense emotions, and improve interpersonal relationships. It achieves this by focusing on 4 distinct core skill areas, and those include mindfulness, which is adopting a non-judgmental perspective toward internal states, noticing emotions before they dictate maladaptive behaviors, distress tolerance, cultivating the capacity to self-soothe and be able to adapt and tolerate emotional pain that cannot be changed in the immediate moment. Emotion regulation, which is to be able to understand the function of the emotions and implementing specific strategies to reduce the affect-laden vulnerability. And then we have the interpersonal effectiveness, which is navigating complex interpersonal patterns through objective self-advocacy and conflict management. So here's where we kind of make that pivot. These 4 skills are effective at regulating human ethic and reducing threat appraisals. And so we can make that shift from it being focused on the client and bring them into more of a supervision lens. where the mindfulness from a supervision standpoint can buffer a trainee's performance anxiety and excessive self-focused attention. With the distress tolerance, from a supervision perspective, it can target some of those self-critiques that supervisees are notoriously experiencing, as well as being able to handle the stress that accompanies those difficult crises that we often are faced with as clinicians. Emotion regulation, it can act as a shield against some of the emotional exhaustion and secondary trauma. And then with the interpersonal effectiveness, this empowers our supervisees to navigate complex multidisciplinary pipelines and manage therapy interfering behaviors. And those therapy interfering behaviors are something that can come in from clients, but also from the counselors themselves. So when we infuse DBT into clinical supervision, we can begin to leverage all of what I'm sure we're familiar with, which is the parallel process. So as a supervisor, we can balance acceptance and change so that our supervisees can see what is some of the things that they might be expecting within their clients. There was a few studies that I did find that infused DBT into supervision. And what they argued is that being able to do this provides a vital psychological safety net for master level and novice interns. And it directly targets some of that performance anxiety, those perfectionistic tendencies, some of the self-criticism. One of the things is a part of DBT is also consultation teams, so it also lends itself to being seen through a supervision lens. And some of the literature that was conducted on DBT consultation teams frames this as it being highly structured. It is something that it offers a regulatory backbone for them, and it functions as therapy for therapists, but it is heavily reliant on being driven with the protocols and making sure that there's trustworthiness with that and being able to provide that feedback, peer-to-peer feedback, so that it can prevent some of the clinical isolation and systemic burnout that comes with working with this framework with some of those high acuity cases. So in this sense, with combining Bernard's discrimination model and DBT, we can build this matrix, if you will, here. And this allows for us to be able to see how a supervisor can step into a teacher role where they can focus on correcting skill deficits, deconstructing technical concerns, and addressing some of those therapy interfering behaviors that I mentioned earlier. Some examples of that may be that maybe they are having some unmanaged anxiety and it could disrupt the alliance. Maybe they are unprepared for their sessions and that's not necessarily helping the therapeutic process. The way that this can be operationalized in DBT is that we could use a behavioral chain analysis and be able to help them break down what are some of the disconnects, and we'll go through that in a few seconds. But then there's also some direct skills coaching, inviting in mindfulness to sort of help with things that may be coming up within their clinical work. When a supervisor shifts into the counselor role, their focus is directly on the supervisee's internal affect, somatic responses, and being able to dismantle that therapeutic phase. So this is a way in terms of DBT that we could use the 6 levels of validation and being able to model radical genuineness to dissolve some of that professional shame or even buffer some of the occupational stressors. And lastly, when we have a supervisor that steps into that consultant role, the focus can be on advanced case conceptualization, navigating systemic friction, such as legislative changes or constraints, and then also working through some peer level problem solving. So a DBT tool that can be used here is dialectical synthesis. So actively guiding the counselor out of the rigid either or thinking to both and, so that we can break up some of that, break up some of those clinical sub points that they may be experiencing. So with the remaining time here, we're going to shift into a little bit of application. And I have some just small case scenarios here. And with this first one, this one targets the baseline and confusion that counselors face surrounding crisis management. So we have a supervisee presents with extreme anxiety and confusion after a client with a chronic illness subtly expresses thoughts of self-harm and then abruptly cancels their next appointment. The supervisee's attention is entirely trapped in a self-focused, self-critical spiral. And they're stating, I'm a terrible counselor, I missed the signs, I didn't handle the crisis plan perfectly, and now they've withdrawn because I failed them. Kind of going back to our table that we just went through. In this impasse, if we look at our matrix, the supervisor must be able to recognize that the supervisee's extreme anxiety and negative self-evaluation are blocking their ability to conceptualize the case and execute skills. So to correct this gap in conceptual mapping and skill execution, the supervisor can explicitly put on that teacher hat, and instead of allowing the trainee to spiral and offer vague reassurance, the supervisor can introduce behavior chain analysis to objectively deconstruct the session dynamics as a series of behavioral links and treating the event as an opportunity for skill acquisition rather than it being an administrative or personal failure. So what that might sound like in the room is a supervisor can say something along the lines of, let's look at the session step by step. Suicide and self-harm risks naturally provoke incredibly high anxiety, and these crisis skills do not just magically appear over time. They have to be behaviorally broken down. So we're going to map that out in a behavioral chain analysis, and we're going to look at the exact moment the client mentioned self-harm, treating it as a puzzle that we're going to solve together. And being able to name it, the tool in this teacher role helps the supervisee be able to potentially utilize this in sessions with clients as well. So you can ask, what was the prompting event before that comment? What were some of the thoughts and somatic stress cues and worries that showed up for the supervisee? And then trace the links between the client's statements and their internal responses. And from there, be able to build a concrete, structured safety and follow-up plan for when they return. So we have another one here. This one is targeting the somatic cost of that emotional labor that we talked about earlier, as well as the fear of being gate kept out of the field, so to speak. So we have an early career practitioner who is experiencing emotional exhaustion. They reported that they're beginning to feel overwhelmed by their caseload to the point that they're experiencing chronic fatigue and intense tension, muscle tension that is, at home. So during supervision, they are trying to maintain that professional demeanor, but eventually they do break down and share that they are embarrassed, they feel inadequate, and they feel as if their supervisor may deem them as unsuitable for the position. So if we hop back over to our matrix here, when this is occurring, we can step into a bit of that counselor role. An administrative check-in at this point might not be as beneficial. So thoughtfully stepping into that counselor role can focus on the supervisee's affect and somatic well-being. And to be able to dissolve that shame performance loop and protect the counselor's health, the supervisor can bypass client strategy just for a moment and utilize some validation, and maybe even model some, radical genuineness. So this normalizes professional imperfection, while also fostering the relational safety of the the supervisor working alliance. So what that might sound like is, you can say I'm shifting into it, or you can just shift into it. You just want to acknowledge that there's a human that's sitting across from you. And just state that given that they're holding several trauma cases while navigating a high caseload, it makes sense that they're exhausted, and completely understandable that they have this strain, and it's cross-contaminating into their private lives. Acknowledging that anyone who's managing high job demands while experiencing such intense tension would naturally feel helpless. So what they're feeling in this particular context is valid. You might even start bringing in mindfulness at this time to combat some of those thoughts that they're having. So with this last one, this is highlighting some of the systemic friction, job dissatisfaction, and even the threat to, the clinical hope for being within the field. So a counselor is working within a state agency and reports feeling completely conflicted. They believe that they either need to sacrifice their clinical integrity by rushing clients through the system to hit administrative case closure metrics and heavy paperwork quotas, or they could focus on deep, meaningful counseling and run the risk of some reprimand or disapproval from management, or even feel like they're professionally drowning. They state that I can't take this anymore. There's no supervisory support or real counseling here, and I'm actively looking for a new job. So if we hop over to our matrix here, in this scenario, the counselor turnover intention is driven entirely by that occupational stress, as well as feeling as if they don't have administrative support. So one way that a supervisor can intervene is to assume that consultant role and treat the counselor as a professional peer, so that they can enhance their sense of perceived organizational support, as well as that work autonomy. So a supervisor can use a dialectical synthesis to be able to, bridge that those rigid systemic constraints with the counselor's need for professional engagement, and being able to kind of break that either or deadlock that they are in. So this is where I'll turn it over to you all, and have maybe one volunteer share what might you say to move from that either or to both and thinking to resolve this concern.
Yes, Dr. Richardson Booth, my name is Diane. I have a question for you, I guess maybe not a comment.
Mm-hmm.
But my question, when you brought the scenario about the client with the chronic illness and they wanted to commit suicide and, the person, the trainee was very upset. Aren't you supposed as a professional, keep it professional, keep it objective, and let the client assume responsibility for the quality of their life? I mean, some people do encounter chronic conditions. Some of them that may be in your DNA, but some and they can be managed. Some people don't manage them. So when they get to the other point, then they say, okay, I want to commit suicide. But shouldn't the client be responsible for the quality of life? And if you've given them all the professional services and resources you can give them, if they make that choice, shouldn't it be on them? And you can just say, I'm free of it, and it happened, but I gave you the very best. Should you have to continue to feel like you're a failure? I mean, because another person wanted to take their life.
I think within the context of the presentation today is looking at how a supervisee might respond to that. And as much as we know what we're ethically responsible for doing, we have our safety plans. We've, gone through what our crisis protocols are to ensure that the client's welfare is prioritized. Sometimes those feelings that a supervisee is experiencing is still pretty present. And so being able to work with them to not feel as if they have failed a client, but to work through what are some of those internal thoughts that they're having and, be able to embrace that vulnerability that they're having in supervision. But in terms of the client itself, we have our ethical responsibility of what we can do. There's a lot that ultimately we can rely on our code of ethics and the safety plans that we have in place. But when it comes to the clients, we would hope that that won't be the outcome. But as long as we've done our due diligence, and I think that we have to rest in that, and that's something that we can share with our supervisees if they're experiencing some of those concerns. I appreciate your question. I am looking at the time, so with this last script, before we get into a little bit more questions, I want to wrap this up and be able to round out the presentation piece really quickly. When it comes to what we can say in terms of a potential script here that we could use in supervision is being able to present those two truths to the supervisee and acknowledge that there are, high caseloads, heavy administrative demands, but that we recognize that this counselor at the same time want to be an ethical counselor who requires work autonomy, who wants some genuine engagement, and be able to kind of map out a strategy where they can leverage some agency resources to protect their professional identity while also doing their job. So when it comes to what I've mentioned today to sort of summarize this paradigm shift that I'm advocating for, let's contrast this with what we may be traditionally using and look at it as a way that we can transform this model across 4 vital dimensions, being the core focus, going from compliance on with logs, compliance with policies and procedures, and really using the supervisory alliance as a way to enact change. Stepping into a little bit more of the teacher, counselor, consultant role away from that task manager and evaluator, helping our supervisees move past the desire to carry that emotional labor and suppress some of that somatic stress that they're experiencing and engage in some mindfulness. And ultimately, ensure that we're cultivating resilience within our supervisees, enhancing their self-efficacy, and being collaborative so that we all have take an approach of a team level duty of care to our clients that we're seeing. So at the heart of what I'm presenting here today is that the vocational capability, the professional identity, the psychological well-being of the counselor are directly dependent on the structural design, the protocol adherence, and the relational safety of the supervisory alliance. So just adopting the mindset that when we protect the counselor, we protect the clinical practice, and ultimately we protect and elevate the lives of the consumers that we are dedicated to serving. Um, with that, these are my references, and I thank you all for your time and your attention and the vital work that you're doing every day, whether it be in education or practice. I have my contact information listed here and do welcome any continued conversations. And at this time, I open the floor for any questions, reflections, or thoughts that you all may have with infusing DBT into supervision. Thank you.
Dr. Richardson Booth, we do have a question in the chat. Do you think that modeling genuineness and vulnerability can help new clinicians maintain self-regulation?
I think it can. The literature supports that. I think when we offer a bit of the humanness, I think there was a comment earlier of, showing who we are and removing. Sometimes what happens is we remove the human from the room. But I think in terms of supervision, when we can display that, we're also modeling to our clients or our supervisees, and they could then model that as well to their clients. So there's a way to be professional, but also acknowledge that we're working with humans and not to forget our humanness as well.
Thank you. A comment in terms of your prompt, a possible response for your example. It sounds like this has been an either or situation. I wonder whether there might be a way to include some aspects of deeper counseling with some clients and also overall progress toward caseload goals. What do you think of this?
I love that one. Yes, that's moving from that either or to both and, which is that, the heart of being a dialectical supervisor.
And then a comment, something that's been seen a whole lot here recently. Too many supervisors are either not qualified or only concerned about numbers or productivity.
Yeah, that showed up in the literature as well. A lot of limited training with supervision, whether it be with the supervisor or there's a need to do a little bit more in supervision given the legislative changes in the rehabilitation landscape where people have different backgrounds. And so because of those constraints, we end up having some of the focus be more administrative, more on the numbers, and we lose sight of the clinical, which is what my call to you all is to invite some of that clinical supervision in and let it be a clinical intervention, because we can see just from what we're seeing with the experiences and challenges that supervisees are faced with, in addition to just thinking about workforce development, it is a tool that we can utilize.
Thank you. We have another possible response to that. It is more difficult to process clients' issues through personal perspectives. It is more professional to separate your stuff from the client's stuff. It can be emotionally draining to carry everything from a personal perspective rather than a professional perspective.
And that's a good one. And that's also modeling, the boundaries that's also a challenge that sometimes supervisors experience. They want to take work home, and you got to be able to maintain those professional boundaries. It's okay to have a heart for what you do, but being able to acknowledge the truth and put the boundaries in place is key.
Other questions?
Yes, good afternoon, Dr. Richardson. This is Diane. I have a question. My question to you is that you say counselors experience burnout. So my question to you, with a master's degree or LPC, what other professions could you pursue? Could it be public speaking? Could it be consulting, where you went to businesses to talk to people who have disabilities, who need special accommodations? I mean, academic advising. What other areas could you use with your degree if you were to be burned out from doing one-on-one counseling?
You know, Diane, I feel a little admittedly conflicted with the question because I don't want you to leave the field. So, I would just recommend just kind of taking a step back and remembering the why. Maybe there are some transferable skills that you could utilize in a different profession. But the undertone of the question is what the literature is showing is that when people feel burnout, they're ready to leave. And my hope is that we also realize that we have a shortage in our field, and what can we do to mitigate some of these concerns? Um, and I hope that through this presentation today that we can see the utility and the need for more support via supervision so that people won't feel as if they need to find a way out of the field and what transferable skills do I have to be able to utilize this in a different career path. So I'm sorry I can't answer it directly. I'm a little biased. I want you to stay in the field. um, so that's my answer.
Thank you. And one last one, looking at the time, just curious, have you or anyone present tried using this model in group supervision? I've been thinking about how I might incorporate strategies in the internship class, and I already know the answer to that one.
Yes, yes, yes. So the reason why this is one of the things that I became interested in is just, looking at the students now. Um, one thing that stood out to me was the need to slow down and see the person as the therapist. And so this is where DBT and supervision came about. Um, so, incorporating some of the mindfulness, the behavior chain analysis, slowing down their thought process and working through. I remember one supervision session. I could just sense by the way they appeared and the initial greeting, how they responded, and let's just take a minute and go through some mindfulness. And they all took a breath and said, yeah, I think that would be helpful. So I would encourage you to start utilizing it. It is a great tool.
Thank you. And Taryn, thank you so much for bringing this work to us today. It truly is valuable, and being able to bear witness to the work you're doing with the supervisees and incorporating this has been incredible. Thank you. For those who are here, ARCA has another presentation coming up next month, and it is entitled The Use of Vocational Experts in Litigation. That sounds kind of interesting. And that will be on July 17th at that same noon Eastern time. And again, I would like to thank everybody for being here and being part of our webinar series. Have a wonderful weekend.